Hello, namaste, and good afternoon. This is Manashvi, and on behalf of ForOptom IBITS team, I would like to welcome you all to our IBITS e-learning session. A brief introduction about our program. The IBITS e-learning session is an initiative by ForOptom, and it is an interactive program where we discuss optometric topics. Before we start with today's session, a small reminder to our audience. Don't forget to keep your mics muted, and if you all have any questions, please type them out in the conversation box and we will discuss them after the presentation is over. Today, we have our honorable guest, Dr. Nitesh Barot, who is going to talk on the topic Is macular degeneration a new disease and what's food got to do with it? Before we start, I'd like to give you all a brief introduction about our speaker today. Dr. Nitesh Barot graduated from Aston University and is a member of British College of Optometry. He has achieved prestigious fellowships of the British Dispensing Opticians and International Academy of Orthokeratology, and he is the president of the British Indo-Pacific Orthokeratology Myopic Control Academy and the founding member of EuroK. He is also the executive secretary of the International Academy of Orthokeratology and Myopia Control and accredited facilitator and member of BCLA and International Opticians Association. Dr. Nitesh specializes in soft and rigid contact lens fitting with a specific focus on myopia control and rehabilitation of traumatized and irregular cornea. So, on behalf of ForOptom IBITS and our audience, we welcome you, sir.
Thank you for the presentation, and I'd like to thank all of you team members of ForOptom to invite me to this meeting. Now, let's start with the topic. What's food got to do with macular degeneration? It is a very, very important thing to think about. Food, what we eat, and how it affects our health. Is macular degeneration a new disease? That's the first thing we need to look at. Because if it is a new disease, then how is it coming along? Now, there are three assumptions we can make. Macular degeneration has always existed. The prevalence of AMD always existed to the degree that it does today. AMD is the inevitable consequence of aging and or genetics. All three assumptions are actually wrong. Now, this is where I'm going to take you on a journey to explain to you why they are wrong. Let's look at the timeline of events that have taken place. Look at the ophthalmology history. Missing from the almost every ophthalmology textbook is macular degeneration predated from 1933. In 1850, Helmholtz invents the ophthalmoscope. Most of the physicians then were much better than us at describing the retina and observing, and the skills they had were much better than today because we are using modern technology, cameras, fundus cameras, and etc. But they didn't have that. So with the dilation, with the ophthalmoscope, they did write everything down. Now, Sir Duke Elder, System of Ophthalmology, a book 1967, explains and mentions drusen as early as 1850. Although he described the deposition of masses of highly material sphericosities called colloid bodies, no mention of macular degeneration. First mention of macular degeneration was 23 years later after 1874 by Jonathan Hutchinson, who had discovered a total of 4 cases only. By 1875, countless papers had been published in relation to choroidal retinal disease, yet no mention of macular degeneration. Germany was first to mention the term disciform degeneration. Wet AMD was clarified by Hermann Pagenstar. Swiss ophthalmologist Otto Hab described senile ocular choroidal retinal degeneration in his lecture in Germany circa 1885. So, looking at the history, there's not much mention of macular degeneration. USA 1893, Doctors Oliver and Norris from the prestigious Wills Eye Hospital published a textbook containing only one paragraph pertaining to choroiditis centralis infection etiologies such as TB or branch retinal occlusion. However, still no mention of any hallmark features of AMD. In 1920, nearly 5 million people in the USA over 65, yet virtually no mention of AMD in any research studies. 1990, Professor Ron Klein, MD, and colleagues found that in persons aged between 43 to 86, dry AMD was 20.9%, late AMD was 1.9%. If same prevalence rates existed in 1920, even with consideration of people over the age of 65, then there would have been up to 1 million people with dry AMD and 95,000 with late AMD. With reference to these values, there would have been a flood of literature referencing it, but not a mention still. In 1930 USA, the book Diseases of the Eye, Charles Henry May reports that high myopia is the most common cause of macular degeneration, central choroiditis, followed by syphilis and contusions of the eyeball. So this is where high myopia has been uh, involved with macular degeneration, but nothing else, not much seriousness about it. In 1938, US study Senile Changes in Degeneration by Human Eye by Benjamin Roth states AMD was becoming prevalent. 1966, Duke Elder mentions infective or toxic influences, possibly in relation to AMD. In 94, US Albert Jacobs Principles and Practice of Ophthalmology states that as many as 15 million persons in this group may be affected by AMD. So until 1994, there was no mention of AMD in such proportions. This is 6% of the population. Now look at the blind registrations in the UK. 1933 to 43 was 6%. 48 to 50 was 14%. 51 to 54 was 20%. 55 to 60 was 25%. 1970 was 24%. 1980 to 81 was 38%. 1990 to 91 was 49% ARMD annual registrations for blindness. This is UK, England and Wales. So you can see it has become a major epidemic now in UK and the Western world. So there is something happening. It wasn't there earlier on, 1933, yet in 1990-91 it has reached 49%. And in 2019 is now at 56% of blind registration, number one blind registration, AMD. Now let's define macular degeneration. Macular degeneration is the progressive deterioration in the macula, the light sensitive cells of the central retina at the back of the eye. As the macular cells malfunction, die, central vision becomes gray, distorted, and is eventually lost. Peripheral vision does not become affected. So there is always peripheral vision, but central vision is lost. So a person will have a lot of difficulty seeing, especially reading, watching television, etc. So it is a blinding disease. Let's look at the pathophysiology of AMD. It's a progressive thickening Brooks membrane interferes with retinal pigment epithelial photoreceptor metabolism. Metabolites from photoreceptors accumulate on Brooks membrane like debris. 1913, Henry Gradel noted RPE disturbances were associated with faulty diet. Now remember this date, 1913, Henry Gradel noted RPE disturbances were associated with faulty diet. 1893, Doctors Oliver and Norris noted impaired general nutrition could play a role in a disease of the vascular choroid, which nourishes the retina, the macula. This is how, if somebody is looking at a person, the central vision loss looks like. Now, if you look at the fundus, the normal macula, you can see fovea centralis here and the macula. Dry macular degeneration, you start to see drusen, the yellow drusen as you can see. And in wet macular degeneration, you start to see neovascularization and leaking of blood at the same time. I'm just going to put a video on, which is very quite interesting. We'll explain to you a few more things here.
Age-related macular degeneration is a leading cause of adult blindness worldwide. This chronic progressive disease affects the part of the eye known as the macula.
Can you see the video?
In a healthy eye,
Is it coming
the
on the screen?
capillaris supplies oxygen and
Yes, sir.
nutrients
The
to the
videos
outer
are visible.
which then pass through Brooks membrane into the retinal pigment epithelium cells. These nutrients are vital to healthy function of the photoreceptors. Vitamin A is one of these nutrients. RPE cells convert vitamin A to 11-cis retinol, which moves from the RPE cell into the rod to be used for rhodopsin regeneration. Normal rhodopsin regeneration is required for normal rod-mediated dark adaptation function, and thus normal night vision. In AMD, the RPE cells become damaged, leading to the secretion of cholesterol, which becomes ubiquitous across the macula. The basal linear deposits form within Brooks membrane, while the basal laminar deposits form between Brooks membrane and the RPE cells. These deposits contain the same type of cholesterol found in the carotid artery of patients with atherosclerosis. This cholesterol layer, which is not visible with imaging technology, causes oxidative stress and inflammation. It also impedes the transport of vitamin A, which impairs rhodopsin regeneration. This localized vitamin A deficiency causes impaired dark adaptation and impaired night vision. These deposits grow over time. Where the deposits become sufficiently thickened, the lesion becomes clinically detectable as a druce. The first visible druce caused by AMD is just the tip of the iceberg of these lesions. As the lesions grow with disease progression, more drusen appear and grow larger, and dark adaptation becomes further impaired. Research has shown that impaired dark adaptation function can be detected at least 3 years before drusen are clinically evident, allowing for earlier diagnosis, treatment, and monitoring of AMD.
Now, looking at what I just talked about, there's two things that came on mind here in the video. You saw vitamin A is very important. Also, a link of cholesterol. Now, cholesterol I'll talk about later on as I go through the slides. But vitamin A is an essential element here. Also, there is a new test we can now see before drusen that we can do a dark adaptation test, which again, there's equipment now available which you can use in your practice. So you can test for this much earlier. How to diagnose AMD? The main test which you must be aware of is Emsler grid as seen by a person with normal vision. And you'll see when they do see this the Emsler grid chart with one eye, and if they see distortion, that is the early signs of macular degeneration. The other way we can do it is with OCTs. Now, this is a normal fundus image of a normal eye. Then we got with macular degeneration, you can see the OCT scans. I'm not going to try and describe OCT today because you can write a book on this. Now, what I want to do is talk about nutrition. And one of the greatest nutrition researchers in history was Weston A. Price from America. Emsler chart is used for mainly to check early AMD, or else we can use the OCT as majority of practitioners in UK are now using. And I will not go into all the OCT, how it's used and whatever, because as I said, there's a long topic just on nutrition and AMD. Now, what I want to do is bring in Weston A. Price, the greatest nutrition researcher in history. He was actually a dentist working in USA. And in his practice, he found that there was so much tooth decay. He was doing a lot of fillings and the jaws were misaligned, teeth were misaligned. And he wanted to find out what was going wrong. So he went on what we call a 10-year research around the world to answer two fundamental questions. Did isolated people living in primitive conditions not suffer from dental deformities, cavities, and dental disease? And if not, did they enjoy excellent general health? What were the diets that would lead to such physical perfection? And these are some of the images of various places he went to. If you look at those pictures, most of them had perfect jaws and perfect teeth. But again, this is an image where he is being to Australian Aborigines who had been placed on reservations and fed white men's food of commerce. The Aboriginal woman on far right continued her primitive diet and had perfect teeth, had no problems. But if you look at the other two on the left side, the deformities, dental problems, etc., was there. He went around Africa, he went around Italy, he went all over the world and did this 10-year research with his wife and found something which was quite outstanding, that people who were on primitive diet were much more healthier and had no health issues, and their teeth were perfect. So if you look at the taste of 18th to early 20th century American cuisine, because I'm talking about America and the Western world, a sufficiency of wholesome and well-prepared food is absolutely necessary to the preservation of health and strength, both of body and mind. Eliza Leslie, a co-author who wrote a book of cookery in 1851. Our ancestors consumed very high amounts of saturated animal fats and extremely low amounts of polyunsaturated fats, the latter of which are present in very large amounts in vegetable oils such as corn, soybean, canola, sunflower, safflower, cottonseed, and few others. So remember polyunsaturated fats and vegetable oil. This may have substantially increased the risk of AMD, rates of heart disease, cancer, diabetes, and apparently many degenerative disorders were extremely rare from 1700s to 20th century. So something here was happening. AMD was rare, virtually non-existent. Now there are what we call displacing foods, which are the culprits. And one of the famous bodybuilders, Jack LaLanne, said once, "If men made it, don't eat it." The standard American diet begins to take shape in the early 20th century. Refined flour production using roller milling technology beginning 1880. Vegetable oil, cottonseed production and consumption beginning 1880 and spreading rapidly post 1900. Now remember, cottonseed is now become edible. Think for yourself, is cotton edible? Yet it's a vegetable oil, 1880. Procter & Gamble, Crisco, hydrogenated vegetable oil transfer fats, invention and mass distribution in 1911. Now this is the margarine, which is touted as a healthy food, and increasing consumption of sugar from 1822. Now refined wheat flour replaced whole wheat flour, which resulted in our first ever processed nutrient deficient food, the white flour. Introduction of vegetable oils severely displaced the consumption of animal fats, which had been a major and primary source of vitamins, fat-soluble vitamins A, D, E, and K. Now remember that video, vitamin A and rhodopsin. So here it is that we are getting rid of that. Increasing sugar consumption further displaced the consumption of even more nutrient-dense foods such as whole grain fruits and vegetables that would otherwise be in our diet. The image that I'm showing you is what we call cold pressed making olive oil. That technology again is not, unless you buy virgin oil cold pressed, that's healthier than factory produced. The other problem we had was the indictment of saturated food and cholesterol as causative factors in the development of heart disease in 1950. So now we are blaming saturated fat as a causative factor and cholesterol. The recommendation for low fat diet late 1970s again made it worse. The mass consumption of processed foods begins. The genetic modification of foods and their mass production and consumption. Before the turn of the 20th century, people had no choice but to consume whole organic and unprocessed foods. The only fat came almost exclusively from animal fat, which included plenty of animal meats, whole milk, butter, and eggs, some olive oil, and for some coconut oil. Cows were grazed on grass. They produced milk, butter that was high in the fat-soluble vitamin A, D, and K. This is what in India, most of the cows were fed on grass, and you have milking done. And most people had even cows at home to milk. The age-related eye disease study, ARED, found the following. Subjects consuming high levels of omega-3 fats and higher omega-3 rich foods had a lower likelihood of developing AMD, omega-3 fats, and higher omega-3 rich foods. Subjects in top 20% omega-3 consumption were 40% less likely to develop AMD during the study. There were trends of decreasing likelihood of wet AMD with increasing intake of long-chain omega-3 buffers such as EPA and DHA, as well as total omega-3s. Now remember, this is AMD, but this was also helping your heart patients if we are taking those. Subjects who were in top 20% of consumption of omega-6 fat and reoxalic acid, which is present in great amounts in vegetable oils, were 1.5 times more likely to be in the wet AMD group than the participants in the lowest 20% AA consumption group. Of the long-chain omega-3 buffers, EPA and DHA, the greatest protective effects for wet AMD were those people consuming the most DHA, typically high fish consumption, or you can have, if you're vegetarian, you can have flaxseed here. Now, what's the perils of displacing foods? The introduction of industrial food processing has without doubt had the most detrimental effect on our health of any other factor in the last few hundred years, and possibly in the entire history of humankind, writes Chris Presser. Cholesterol. Now, there's two types of cholesterol, HDL versus bad LDL. Now, remember in the video, we talked about cholesterol and AMD. Dr. Fred Kummer, a scientist at the University of Illinois, cholesterol has nothing to do with heart disease except if it's oxidized. He goes on to explain the process of oxidation of LDL is particularly severe when vegetables are subjected to high temperatures, such as frying. Now, remember, in the West, we've been doing this for a long time, but now India and Southeast Asia, again, frying is becoming a big, big thing. Atherosclerotic plaques equals oxidized LDL. Lower density lipoproteins have been found in the retina and the RPE as they are important to the retina's lipid supply. If LDS is there, then we also know that oxidized LDL is there. When blood test is carried out for MD, higher oxidized LDL has been shown in blood supply. Lipid purification products which come from oxidation of polyunsaturated fats, purpose among which malondialdehyde is higher in AMD patients. Evidence shows oxidized LDL and consumption of polyunsaturated vegetable oil is the cause of AMD. USAID Food Fact Sheet, October 2012. 1 teaspoon of vegetable oil contains vitamin A 0, vitamin C 0, calcium 0, and iron 0. Soya bean, some vitamin E and some K 1. Vitamin K2 is important in preventing atherosclerosis and also for depositing calcium in bones and teeth. The purpose of displaying foods. White flour pretty much wherever it shows up throughout the world, metabolic havoc ensues. Now, if you look at that gunty on the right side of your picture, that's how traditionally we used to make the flour. Now that does not happen anymore, does it? It's all buy from the supermarket. Now, University of Minnesota nutrition researchers described flour extraction in two ways. When extraction rate is 75% or less, is equal to white flour. And if you look at this table, which you can read at your own time, has got wholemeal is 100%, has got so much fat, fiber, calcium, phosphorus, zinc, copper, iron, thiamine, B1, riboflavin, B2, vitamin B6, folate, biotin, and niacin. But when you have white flour, most of it is virtually gone, or it's 50% or 60% less. Now, AMD and cardiovascular disease are strongly connected. So it's very important that if you try and prevent AMD, you're going to help somebody with their heart problems too. Whole grain studies, David Jacob, PhD, and Lynn Sippon, PhD, in a paper presented in the American Journal of Clinical Nutrition. And also, these are all the other research papers which are written by our Women's Finish Study, Nurses Health Study, and rest. And all said whole grain reduces cardiac risk. Whole grain also reduces risk of diabetes, cancer, and obesity. AMD and cardiovascular disease are strongly connected epidemiologically, clinically, and from the standpoint of biologically plausible mechanisms. Researchers from Rotterdam studied the risk of AMD to nutrient intake. Vitamin E, called tocotrienols, is abundant in whole grain food in wheat and oil germ. Multiple studies have shown tocotrienols suppress angiogenesis, new vessel growth. Remember late AMD, new vessel growth. So by just taking wheat, which is not white flour, natural wheat, there is actually stoppage of vessel growth. So we can prevent late AMD. This occurs through what is called inhibition of the VEGF as well as VEGF receptor signaling. Now remember, VEGF at the moment, when late stage of AMD, we are using either laser or injections to control it. But that's too late. We are actually at a point where the AMD is making person blind. So we can prevent this happening in the first place. What this means, whole grains may help suppress the development of wet AMD. This study also found that delta tocopherol suppresses VEGF, whereas alpha tocopherol, the type found in vitamin E found in virtually all supplements, does not do that. So vitamin supplements are not the answer. It's the food that's the answer. Sugar disease and macular degeneration. Sugar-induced AGEs, which is ultimately damage to RPE cells, which may then become incompetent to manage the task of properly supporting the photoreceptors. Researchers in Singapore studied metabolic syndrome and its relation to MD. The conclusion: metabolic syndrome, obesity, high glucose, high triglycerides were predictors of progression to late AMD. So sugar is quite indicted here. An epidemic of vitamin deficiencies. 13 essential vitamins critical to humans: the fat-soluble A, D, E, and K, K1 and K2. Water-soluble vitamins B complex, which is B1 thiamine, B2 riboflavin, B3 niacin, B5 pantothenic acid, B6, B6, B7, B9, and vitamin C. Vitamin A, D, and K plus lutein and zeaxanthin deficiency associated with AMD. Do synthetic vitamins slow the progression of AMD? Age-related eye disease studies are Agerelated. The experimental group that received the antioxidants had reduced rate of progression of intermediate AMD to advanced stage of AMD by 25% over a period of 5 years, with an associated 19% reduction in the risk of moderate visual loss. So if somebody has got AMD and if you put them on, you may delay the progression if you give them supplements. So supplements do help in some way once you have got AMD, but not ARED's vitamin supplement have not shown of prevention of AMD. So the supplements will not prevent. This is very important note you have to make. Could the ARED supplement make AMD worse? Now this is again a question. If supplementing somebody with AMD with supplements, Carl Ho, ophthalmologist and vitreoretinal specialist and colleague, evaluated data from patients in ARED. The patient with high CFH and ARMS2 are both genotypes that affect AMD. 13% of the entire group of subjects had a 135% higher chance of progressing to advanced AMD. Now here, what he's saying is that if there is a genotype affecting AMD, and therefore if you give the supplements, it actually may make it worse and it may progress faster. So one has to think, is supplement a good idea, vitamin supplements? History tells us let's look at the ultimate plan to prevent and treat, possibly reverse early MD. History tells us MD was close to zero between 1850 to 1920, becoming prevalent enough in the 1930s. Again, we talked about Duke Elder, senile macular degeneration is a common cause of failure in central vision of all people. No statistics were given relating to dry AMD. 130 cases have been reported in the literature. So we're going back to the timeline here. Today we see that AMD afflicts 17 to 40% of those people age 75 and beyond, based on 7 different studies on different populations. What are the main causes of blindness in adults in UK? 48% of people are blind due to AMD, 17.5% due to glaucoma, 16% due to cataracts, 9% due to other eye diseases, 8% due to diabetic eye disease, 2% due to refractive error. So you can see on top of the list, it is AMD, 48%. Why we have an epidemic of AMD today? What we were eating then, and how what we are eating today, and how are they different? Incubation period for AMD is probably 30 to 50 years. So you in India and Southeast Asia need to be aware that it's 30 to 50 years the incubation period for AMD. If you look at this graph, it tells you the story from virtually, if you look at the sugar consumption, 1840 onwards, and 1920 was rising, and then it came down a bit in 1940s, then went up because of the war. There was sugar shortages in the Western world, and then it went back up again. But if you look at from 1900, total vegetable oil consumption was rising and rising, and it's still rising. And look at the jump for AMD. It's rising virtually from 1930 onwards, and it kept on rising now. So it is now afflicting major populations in the Western world. But it's the same story. The vegetable oils are becoming very, very popular now in the Southeast Asia and India. So we need to avoid certain foods which are what we call displacing foods: white flour, sugar, Polyunsaturated vegetable oils, primary soya, corn, cottonseed, canola, rapeseed, grapeseed, sunflower, safflower, rice bran, mustard oil, and anything labeled vegetable oil. Avoid anything that says vegetable oil because high heat is applied to get that oil and that it's devoid of any nutrients. Trans fats, hydrogen and partially hydrated oils, common in shortening margarine and puffer vegetable oils. Any processed foods, which are mostly a mix of previous four, pasteurized dairy plus hundreds of thousands of proprietary mysterious ingredients often labeled artificial flavors. So in reality, we need to look at back at what our grandparents ate, and they ate all natural foods. But in reality, none of us are doing that. If you look at, in fact, I've been putting some on my Facebook, my what I have for breakfast and everything, and I've been looking at what other people have been putting, and it's all fried foods. If you look at those posts, you can see where the problem is going, and all the Indian foods are all fried at the moment. I'd like to thank you. So if we can reverse the AMD, provided we change the diet, we go back to what our ancestors ate, that would solve our problem. Thank you for listening. I hope I was not too fast, and hope this is not just a lecture for all optometrists, but it would help with other people too. We need to educate the population around the world what needs to be done. Thank you. Any questions?
Thank you so much for the presentation, sir. I'm sure that our audiences have also immensely enjoyed the presentation. So I'd like to tell the audience that we're open for the questions and answers session. So if any of you have questions, please type them out in the conversation box, or you can just switch on your mic and ask directly to sir.
The diet I would suggest for Indian context would be that, let's say if you have brown rice or khichdi is good for you, lentils, rotlas, brown rotli, brown flour rotis. Trying to avoid anything that is like, today's fashion is becoming in India. I've noticed that people are eating a lot of pizzas and all this, which is all white flour. The cheese is not natural. They're putting chemical cheeses in those things. So natural cheese, natural ghee, natural butter, all this is good for Indians. Like, looking at it, we should have never actually blamed butter or ghee as a problem for heart problems. I think vegetable oils are to blame for AMD. So let's go back to what we used to eat. You know, any dairy products is good enough for you, and fruits and vegetables, obviously, and your spinach and all else.
Thank you for the answer, sir. Similarly, related to ARMD, a lot of patients, we have a hard time explaining the patients that, we do not really have a certain, a proper treatment plan for it. So how do you suggest we approach those patients?
I think what I say is, a good optometrist, we need to treat the symptoms, the person, not the symptoms. So even if there's no symptoms, if even a young person comes into your practice, you need to start talking about diet, because vitamin and all this is very, very important that they are aware of. This is not just going to be prevent AMD. We're going to make them more healthier. We're going to also, in fact, diet plays a lot of part in myopia also. So, I mean, I personally think myopia increase is not just related to these mobile phones and digital devices. It is also related to the diet you consume today, because all this has all gone a lot more. So prevention is the better cure, and you will do better by explaining this. Take time with your patients. Don't just rush them through and try to dispense something to them only. To me, to in my practice, I spend at least 10 minutes minimum on explaining their health issues. After taking history taking, you find out what they've got problems with. Explain this. Hope that answers your question.
Similarly, we hear a lot about prescribing the supplements to the patient, especially the supplements of vitamins. So, are they any good, or do they really help in the cases of ARMD?
Supplements, you need to be aware. In my lecture, I explained to you, if there are genotypes which patient may be genetically susceptible, then you may need to avoid the supplements just in case you may aggravate and start the AMD. Once AMD has started, then yes, you can use supplements and diet also. But do not give them supplements on just on the basis of to prevent, because all the studies that have been done actually show that supplements may not have, they may actually speed up the AMD. But
And
vitamin A supplements, people do give other supplements, but that's something which you need to bear in mind. I've got a
okay,
question here on blue light, on MD.
yes.
Blue light, yes, it does cause AMD, but it's not definitely on research hasn't been proven to cause AMD. So I do not think blue light is the real cause, because I said to you earlier in my lecture, it's 30 to 40 years for AMD incubation period. So it is the diet which is what has caused it, because it was never there before 1930. It was not a major problem. Okay.
Thank you so much for the answer, sir. Now we're wrapped up with our questions. And on behalf of IBIDS and our audience, we would like to thank Dr. Nitesh for giving us your valuable time and the lovely experience and knowledge that you have imparted on us today. So I'd like to request you to share your experience on the IBIDS team today.
I would say you are organizing a very, very important thing here. It's an education platform you created, and for Optum, of the creation by all of you, I'm really actually amazed by what you're doing and the number of people who actually joined us today. So to me, I would just salute you guys for making for Optum, and hopefully I may help you in any way I can. I will do so. And thank you
Thank you
again
so
for
much.
uh, to present today.
Thank you so much. Thank you so much for your kind words today. And we will definitely take up on your offer, and we will require further help from you in the future. And we will be connecting with you and our audiences. And this brings us to the end of this session. It was an honor to have you here, sir. And I would also like to thank our audiences for being so supportive, kind, attentive, and interactive. And on that note, I would like to end the meeting. This session will be on YouTube soon. Stay tuned for more sessions and programs by IBID and ForOptom. You can also visit us at www.foroptom.com for more information on ForOptom and IBIDs. Also, join us on social media, WhatsApp, Facebook, and Instagram. Stay home, stay safe, and have a great day. Thank you.